Okay, so in the last presentation, the one that I gave to the district speech therapists, it wasn't a popular presentation. I suppose that one thing that makes us human is our resistance to change. So it makes sense. Here I was, a clinical fellow with zero experience, telling them that the district needs to change its programs, that it needs a program for addressing something that they didn't think needed to be addressed. So who did I think I was, right? But anyway, there were a handful of us who were passionate about feeding our students. And we got together to discuss the next steps, and that's what we'll be talking about in this video. So, first of all, we absolutely need to provide services for addressing feeding disorders. Okay, like we said in the last presentation, 1 in 37 children under the age of 5 are malnourished and or they have feeding disorders, and therefore they're not meeting academic performance benchmarks. So, especially now, budget cuts are limiting our students' access to nutrition in schools. School nurses they already have cases of this, but they currently don't have specialists working on swallowing and sensory feeding. The reason is that the roles and responsibilities of other clinicians aren't defined yet. There's no guidelines for what services can or can't be provided. In a lot of ways, this is an untapped resource. So, we've based this proposal here during this presentation. We've based it on the models recommended by ASHA and models that have worked in other school districts before. So parents are currently asking for IEP support for feeding, but we don't address it because there's no plans or procedures in place. Right. District admins tell parents that we're ready and willing to help, but we don't have any clear way to do it. Our administration and school specialists want a framework that clearly defines reasonable accommodations, modifications, and supports that we will or won't provide. Our proposed guidelines need to be consistently implemented across the district. So both ASHA and IDEA provide some guidelines. Um, Schools are mandated to perform interventions to serve educational impact. It's the school's responsibility to ensure safety, physical well-being and energy, and school performance. Therefore, schools are responsible for providing services that address pediatric feeding disorders. So, there are a few obstacles, right? Here are among the most common that I found during the interviews that I conducted. Okay, SLPs and OTs, among other specialists, complained about having too many students on their caseloads. This was a result of inadequate funding, and it leads to their inability to take on new cases. They believe that it would require special equipment and extra time, which again needs more funding. Another concern was liability. They worried that cases like these would be a little bit more risky or dangerous, and it might require additional training. And it will require additional training and practice. And it's currently unclear what's within and outside of their scopes of practice. And then finally, a final concern is how addressing these feeding disorders is even relevant to our students' education, right? We just talked about this, but our specialists have gaps in their training. If you ask the specialist, why do you think it's important to feed our students in order to help their academic performance? There's gaps there. Okay, they might say, I don't know. So addressing feeding disorders is already part of the school nurse caseloads, but they haven't been addressed to the best of the school's abilities. Proper nutrition and hydration improves academic performance, period. Addressing pediatric feeding disorders is absolutely relevant to education. So, to address these obstacles, we outlined this plan. Okay, instead of requiring all SLPs in the district to manage feeding cases, there should be a small team that handles them for the entire district. This group would be expected to maintain specialty certifications, communicate with relevant healthcare legal professionals um, or specialists, and manage the referrals. Okay, there needs to be a written framework as well that outlines the roles and responsibilities of each specialist. It wouldn't just be SLPs, right? And so this framework, this written framework needs to outline their roles within the bounds set by their governing bodies. So ASHA for SLPs, AOTA for OTs, etc. And this team should be well trained in documentation and reimbursement and provide general trainings for the district SLPs, OTs, and school nurses to make sure that they know how to refer. The written framework can be revised as needed until the district can officially adopt it, or even after the district has officially adopted it. So who's going to be on this team? Well, at least two SLPs, two OTs, and one school nurse. Pediatric feeding cases across the district will be referred to them, and they'll travel across the district to perform screenings, evaluations, and treatments. Um, they'll be general specialists, but they will be specialists and handle all the cases across the district. Um, And then what will the framework address? It will address how to document these cases on Embrace and Skyward, okay, and how to bill Medicaid. They'll handle a collection of forms and handouts for referrals and screening. That should be part of this framework as well, so that it's standard across the district, which um, they need to know which aspects of pediatric feeding disorder management are important to convey to the district during in-service trainings. Um, and they need to, it needs to include, this framework needs to include how to acquire funding for materials because it will require funding. And how would this framework be implemented? It would be a three-phase type of implementation, right? So generally, this first bullet point here says that it'll be slowly at first to work out the bugs. We'll start with just a handful of pilot schools, and then with the district split, I'm not sure whether this project will survive or in what districts they might want to do this in. But the schools we selected, a couple of years ago when we introduced this plan, they did remain in the same district, so they could potentially collaborate still after the district split. Eventually, we'll test the framework on bigger portions of the district. Um, and then eventually, the entire district will receive the trials for implementing this plan. Um, the any revisions to the framework will be based on educational outcomes and employee feedback. So it could be a living sort of document, and it'll be based on how well the students perform academically and how the employees are able or willing to implement this plan. Okay, and then these are our proposed phases. Phase one will be piloting. Phase two will be forming the traveling team formally. And phase three would be identifying the picky eaters and oropharyngeal concerns with their existing health plans. Again, we're going to start slow and steady and work out the bugs, and this might take a couple of years. So to recap, why are we doing this? First reason, to ensure developmental potential by maintaining adequate nutrition, hydration, and health so our students can access and benefit from the education program in whatever district this is going to be implemented in. And then the second reason is to develop optimal service delivery models for managing pediatric feeding disorders in the entire school district. And so that was the presentation, the proposal to the district. Thank you so much.